it's out there. They're using it. It's because for years trauma docs have been using this for prophylactically for pulmonary contusions. So I would rather use this because we know that first 3 days after a nasty pulmonary contusion, it can manifest itself in a nasty way. And so if your goal is to keep a constant pressure and keep them recruited and be gentle with ventilation, then so be it. I think that can keep you from developing ARDS. And but that was a standard of care for a while that trauma centers were putting. I'm glad we never did. But because the acuity would go up so much, but they put them on high frequency oscillators for pulmonary contusions from day one. But it's just a lot of charge for something and compared to the way we do it. Now we do everybody pressure modes, which is better off than what they probably were using before. So I'm still comfortable the way we manage our pulmonary contusion patients. So, but yes, APRV for pulmonary contusions is great, especially if you see it manifesting itself. You might as well jump to it. But my challenge is that we would wake them up a lot more so they can fix their CO2. So we're not chasing that. I hate to chase two variables when I can let the patient fix one of them. And then all I have to chase then is PO2. Me and you are just trying to figure out PO2 for the patient instead of both. And then it eliminates us having to figure out rate and everything else. We can just work on I time and get their PO2 up. So, in review, we talked about the difference between positive pressure and spontaneous breathing patients and what to reconsider every time you change one of these settings because of slide number 1. We also talked about the difference between volume modes and pressure modes and why your patient would be on a volume mode. The healthy lung individual, post-operative cases are all fine with that. We talked about when it would be time to switch to pressure control modes, and y'all understood that, and y'all understood why pressure control was better at that point. Then we talked about the twofold benefit of PRVC, volume guarantee with the gentle flow characteristic and the high mean airway pressure associated with the pressure mode. The bad thing about PRVC was it is a control mode. So your options then are to either go to some sort of support mode, such as pressure support or volume support. And then we talked about when you would have to go back if they desatted or if they got tachypnic. And then if you did try to go back and you couldn't paralyze them, then at that point, bi-level or bi-vent would be a choice for your patient. And then we also talked about all the ways that you can increase your patient's oxygenation by using mean airway pressure. Always reconsidering, though, their cardiac output and their hemodynamic status every time you make a change, because that's what you're pushing on every time you change that. And I think that some of this will help you, at least when you're at the bedside, looking at your patient's pressures, the vent settings, and what mode they're on, and then look at the gas and look at the diagnosis and say, okay, they're probably on this because they're pulmonary contusion, or probably on this because their peak pressures were high. And so now to help you make a little more sense of why your patient's on what they're on, give you a little ammo at the bedside to think out loud with somebody what's going on with your patient. Y'all have any questions on anything? I know y'all walked in on the after the first two slides were pretty fundamental and establishing the rest of it, but y'all have any questions? You think it's beneficial?
Yes.
Okay, good.
Can you go through like the sequence of things in exercise? Say if someone has a saturation of 80, and you've checked the obvious things, you suction them,
yeah,
at good breath sounds.
Yeah, if they're on
sequence of things, and let's say they have known ARDS.
Okay, so this is an ARDS patient.
Yeah.
We know they're ARDS. Okay, they're ARDS. We have a SAT of 80. Let's go ahead and
Can't stand
let's say that they're on 100% oxygen, right?
Yeah.
So we have no option there. As soon as you call the therapist at bedside, they're desatting, they're at 80, they're not climbing at all. You suction. You understand that they, if there's an increase, I listen to breath sounds, obviously. You listen to fluid status, make sure that they're not more wet. If they're more wet, you still got to fix it. You can't just say, well, their stats 80 are wet. You got to fix it.
Can't give them Lasix right away.
If they're wet, if they're wet and they're crackly, I'm going to use some PEEP on them.
Right.
And I'll tell you, the first thing I'll try is I'll always increase PEEP first. And what I'll do is I'll increase PEEP by doing a little miniature best PEEP study. I will go up on the PEEP by 2, and I don't necessarily watch the SAT. I'll watch my compliance. If my compliance gets better.
Can you explain what compliance is?
Yes, compliance is volume over pressure. So, compliance is the ease of which it takes to open your lung. If I, for example, right now, you're not intubated, you should move 100 cc's per every 1 centimeter of water pressure I push in your lung. When I intubate you, your compliance should be roughly about 75. That's if you're healthy. cc's per centimeter water pressure. So, if I'll tell you for real what compliance is. If your peak is 32 and your PEEP is 5, what's your delta P? We talked about this a little bit. What's your delta P?
27.
Good. It's taking 27 centimeters of water pressure to move 500 cc to tidal volume. So if you divide 27 to 500, you get your compliance. Okay. So if I go up on your peak, let's say I go to 7. So I'm going to go to 7 now. You would assume that your peak would go up by 2 also, right? Because here's your baseline, here's your PIP. You're breathing right in. It's taking that amount of pressure to open your lung. Well, if I stair step your PEEP up by 2, should your top number go up by 2 also, right? Should go up the same amount. But what if it stayed 32? It means your lungs like it. Is that a good? Does that make sense? Now look, what's my delta P? It was 27. Now what is it? It's 25. It's now taking less pressure to move 500 cc tidal volume. So that means I opened some more alveolar units. So now that pressure, that volume has a place to go with less pressure. That's what I do first. I go up until your compliance goes, and I go up until your compliance plateaus and drops, and I go, okay, his lungs don't like any more than 18. So 18 is the maximum amount. But if I go to 18, and that's the best compliance, but his blood pressure is low, then what do you think? It's a Q problem. Because your lung is saying yes with the compliance, but the blood pressure is going down. I'll ask for a fluid bolus at that point. Because I know that the lung is saying yes to all this stretch. And that's what I'll do. I'll go until the best compliance. At that point, I'll ask for fluid. Or sometimes you don't need fluid. Sometimes you can go up and come back down and have a best compliance on your way back down. And that's what I do first. So I go up on the PEEP till I plateau the compliance, and then I come back down and I pick the best compliance, and the SAT's going to follow. I don't have to wait on the SAT. Wherever your best compliance is, that means I've opened the most lung. The SAT's going to follow behind you. So that's the first thing I do. If that doesn't work, if I pick a best PEEP based on compliance and the best SAT I get, Dr. Simpkins, is 85, you're thinking, okay, Ryan, you didn't cut me any favors. SAT's 85, and so what? You got a best PEEP now. Well, then what I need to do is I need to do what's called a recruitment maneuver. And I'll do a recruitment maneuver on patients, and what I do is I'll take them and put them on you can either do it bi-level mode or CPAP, and I'll just take their PEEP and not put a PIP on top of it. Take their PEEP and crank it up to about 40 or 30 or 40 for 30 or 40 seconds, as long as they can handle it, and then come back down to the best PEEP that I had. What that recruitment does is it sustains inflation and hopefully starts to recruit. You can see as I have my lung open, I'm going to recruit. This pressure has to go somewhere. And then I come back down to an adequate PEEP. I've kept it open. It's that theory of once you blow a balloon up and it's partially inflated, is the next breath easier than the first or harder? It's always easier because it's already open. With a recruitment maneuver, I've inflated all the balloons, so when I come back down to a decent PEEP, now every subsequent breath takes less work, and you'll see your peaks drop out when you do that. Your peak pressures will come back down if you've recruited. I'll try a recruitment maneuver next.
So the successful recruitment maneuver for you, not necessarily the oxygenation, but it's better compliance.
Yes. And because, well, if this isn't a problem, I'm not going to come up and show up and do it. This is telling me I have an issue with compliance and the lung opening. If this was 95, I'm not gonna worry about compliance or anything else. I'm going, that's a happy SAT. We're doing fine. But a recruitment maneuver for me is typically going to be, this didn't respond to my best PEEP study, so now it's time for a recruitment maneuver. Did you see that? I do this first, PEEP study, then a recruitment maneuver. Now remember, during this whole time, I'm going to be questioning Q, because I'm telling you, I can't fix this SAT if I know that it's a fluid problem. And I know with trauma patients, it's very difficult because they're head injury. You don't want to juice them up with all this stuff and get cerebral edema and give them